I'm Brent Keeling of the National PERT Consortium at Emory University. I'm here talking today to Vic Tapson, also the National PERT Consortium of Cedars-Sinai. Vic, thanks for talking with us.
Brent, good to see you, man.
I understand at this national meeting you've introduced a new dress code.
Well,
As such, I'm going to oblige. I'm not going to take it off entirely, but
loosen up.
Loosen up a little bit.
Man. I like that.
This is meant to be
Makes
informal.
me feel better. I feel loosened up just by using
Good, excellent. So Vic, what got you involved in pulmonary embolus care and pulmonary embolus research? Why are you interested?
Well, I can tell you, the PE's been a fascinating topic for a long time. I mean, in the early 90s, we started doing some animal research in PE just because we had a couple cases at Duke that were just devastating cases. I remember a young woman that came in, pregnant woman, 6-month pregnant, came in, was sent home by her doctor a couple of times saying she was short of breath because she had gained weight, she was pregnant, and she came back to ED and died of a big PE. We had an autopsy. Horrible.
Right.
I remember the case very well. We got started with some catheter-based treatments in the early 90s. We'd go to the cath lab, take these patients in with big PEs, try to lyse them with low-dose TPA. And frankly, and urokinase back then, and streptokinase. And I must say, we could have got the PERT thing off the ground back then, but I felt like back then I was the only one that was interested, and so coming in the middle of the night and then coming and doing clinic all day and around the ICU was kind of tough. So we kind of disengaged from that aspect of things, but I'll tell you, I stayed very interested in PE, Brent. I think the thing I like the most about it, and I think many people share this passion, you see a patient, they're suddenly very sick, and you got to figure out what to do.
Right.
And we're getting more and more options.
Yeah. To that end, how have you seen the care of pulmonary embolus change with the evolution of the PERT concept?
Yeah, so I think the team concept is really key. I think when one person does things by themselves, you often get a lot done, but a team makes a big difference. What I love the most about this, I think, is the multidisciplinary nature of it. We had pulmonary, cardiology, critical care, interventional radiology, ED, hematology,
surgery.
Yeah, no, I was saving the best for last.
That's right, of course.
You know? So, and I think, one thing about our center at Cedars, Brent, is we pull that together, I think, really pretty well. Everyone's involved. For example, we've got great surgical responsives. Our surgeons, when we need them, they're there. They live in the hospital. You guys are, it's unbelievable. And I think that multidisciplinary aspect makes us really realize that you can do a lot more with the team than you can one person.
Right. Well, I couldn't agree more. I am going to hold you personally accountable, though, for the fact that there are only 3 pulmonary embolus response teams in the state of California. Yeah. What's preventing widespread adoption and more people kind of taking hold of this?
We got to try to stop covering the entire state. It's getting tiresome, you know. But yeah, it's a great question, and I'm not sure what it is. But we're getting. I think things are starting to expand. You know, we've talked to folks in San Diego, a few folks between us in LA and San Diego. We got to get work on Northern California. It's going to happen. It's going to happen. I think it's just a question of getting things moving. Right. We need to get a little. I've had a couple of colleagues talk about why don't we get a little mini California PE consortium going that can be part of the big consortium, and we haven't really talked about kind of statewide things, but it's going to happen. I think what we're seeing now is just population on the East Coast is making this bigger, but I think I predict. I hope I'm right, Brian. I predict this map's going to look different next year or the next year.
I
hope I'm right.
Yeah. Lastly, where do you see the future of PE care going? 5, 10 years?
Great question.
I'll let you go.
I think what's going to happen, Brent, is we got to get some of these big studies done. We got to learn how to best do catheter-based therapy, who to do it in. We're studying new drugs now. We're doing a great study with a TAFI inhibitor. I'm excited about it. Thrombolytic-like agent. Maybe this drug will be the way to go systemically, or maybe we'll use it in catheters if it proves fruitful. Studies looking at which is the best catheter-based approach. We got to learn all this stuff, and I think research combined with this patient care approach is going to be what's going to get us there. We got to get studies done, so we got to learn to risk stratify, Brent. We got to, how do we do it right now? We love the European risk stratification program, like the SPESI. It's not perfect. It's maybe the best we have. We got to learn to really risk stratify.
Right. Vic, thanks for your time.
Thanks, buddy.
Brent Keeling, Vic Tapson, National PERT Consortium.
And take that tie off, damn it.
I will, right now, sir. Thanks, man. It was fun.